Hey everyone, welcome back to the Unspoken, the podcast that aims to discuss everything not discussed surrounding transplant and donation. Thank you again for tuning in. If you haven't already, hit that subscribe button or follow. Depending where you like to listen, please do so. I first want to apologize. We did take a little bit of a hiatus just due to how crazy things were over here at CKF, but also just a few scheduling issues with our speakers. We have 4 amazing speakers lined up for the rest of the year who are going to bring some amazing insight onto some topics not discussed enough surrounding transplant and donation. Our first speaker today is going to be Dr. James Trotter from Intermountain Health, and we're going to be chatting about organ pumps and the difference and the impact that they've had on not just liver transplants, but also kidney and other solid organ transplants. So I'm really excited. This is a topic that I think a lot of people don't really know anything about that side, or at least transplant recipients. And I think it could really be beneficial to know a little more, especially those who are waiting for a transplant. So please tune in and listen to that. But before we delve into that, let's check out what CKF has coming up through fall and the holiday season. First up is our back to school campaign, which is for elementary, middle, and high school students. You can order it as a classroom, as a school, or to do at home with them. It includes numerous school supplies, thanks to our sponsors, the Ritz-Carlton Aspen Highlands, including notepads, pens, pencils, coloring pencils, folders, literally everything you can dream up. It also includes games and activities and a full lesson plan to help you really educate your students or kids about the importance of registering as a donor. It is obviously age specific, so elementary is going to be really the basics, whereas high school we're going to be delving into everything. There's trivia, there is bingo, there is scavenger hunts, all to make that learning come to life. So to order a box, head to our website, Chris Klug Foundation/donor dudes. Next up, Halloween is nearly upon us, and that means we want you to haunt it or flaunt it with us. Our Haunt It or Flaunt It campaign aims to show the world why organ donation is not spooky, and share, sort of a fact or your favorite reason why you don't think organ donation is spooky and others should agree with you. Just hashtag Haunt It or Flaunt It and tag CKF for a chance to have us reshare your post on our social media. Our New York Marathon team is headed to the Big Apple on November 2nd to raise awareness and funds for the foundation and our mission to eliminate the wait. If you haven't already read through their stories and connections, please do. They have some incredible stories and reasons why they are racing this year. And if you feel so inclined, you can make a donation to help them over that fundraising goal. We want to say a huge thank you to all those who have donated and supported them so far. To find that, also head to our website /New York Marathon. Finally, Summit for Life is right around the corner, and if anyone knows CKF, they know we love Summit season. So Summit for Life is our longest standing and biggest fundraising and programming and awareness event of the year. It is 500 people join us to hike up Aspen Mountain on December 6th, all in honor of organ and tissue donation. And they do this 3,267 vertical feet climb in the dark, either snowshoeing, skinning, or hiking. They're crazy. I am a solid gondola rider, as anyone who knows me will have heard me say. So it's also open if you are not up for hiking the hill and you just want to ride the gondola to the top. You can totally join me. And then we have a big party at the top and celebrate the gift of life. We honor our Michael Wells Inspirational Award winner each year, who is an individual who has done great things in the transplant and donation community, usually local to Colorado. And it's just such a wonderful event. And if you haven't joined us already, please sign up, come and join us. It's so fun. And this year is going to be bigger than ever, as it is the 20th anniversary of Summit for Life. Now, without further ado, I can't wait to welcome Dr. James Trotter onto the Unspoken podcast. First off, I really want to say thank you for joining me. I'm so excited to have this discussion and learn a little bit more about a topic that does not get discussed enough, hence the name The Unspoken. And today I'm going to be joined by Dr. James Trotter, who is based in Salt Lake City with Intermountain Health. And I'm really excited to kind of delve into the world of organ pumps. So thanks for joining me, James.
Well, thank you very much.
Awesome. So first, can you provide me like an overview of what an organ pump is and what the current, use of that is? What are they being used for at this precise moment, and what are those benefits?
Well, so there's I won't go into all the different types, but there are different types of organ pumps. But I think safe to say that these are devices that where a donor organ can be placed on a pump outside the human body, sometimes inside the body. It can be perfused with nutrients and blood, and during that time, the organ can be tested with by blood testing, observation, to determine if the organ is suitable for transplant. I won't go into all the different types because it's probably beyond the interest of the audience here, but they're proprietary devices that are made by companies, and there's some devices that are basically the combination of old technologies, but they allow essentially for once the donor is deceased, the organ can be perfused and provided nutrients. And during that time, the organ can be tested to determine if it's functioning well, and um, allowing us to use a higher number of organs that we used to have to discard because of fear that they would not work well. So this technology has really become more popularized in about the past 5 years or so. And as a result of the use of the technology, the total number of liver transplants has increased by probably about 20 or 25%, where we were doing around 9 to 10,000 a year in the country. Now we're up to probably 12,000 or more a year. And so it's increased the utilization of organs that we used to discard. It's allowing surgeries to be timed in terms of hours, where an organ can be placed on a pump, and the transplant can occur at a business hour when teams are rested, especially if they're doing multiple cases in a row, or allowing a patient to come from a distance without having to have the organ be in cold storage where it could deteriorate. So the main thing is it's allowed the use of organs that used to be discarded. The organs can be tested while they're on the pump to make sure that they're functioning well before they're put in. And the whole result is that it's increasing the total number of transplants. And there's particular centers across the U.S., as we were discussing before we went on, that are doing a really good job of that. And it's really fundamentally changing how we treat and practice our trade.
It's definitely helping out and making a difference. And I'd imagine not just on the recipient side, but on the donor side as well. I know my mother-in-law, my brother-in-law was a donor when he passed, and she said half of the hardest part was, they have to keep the donor alive to do all the testing and everything else. So I'm sure this helps a little bit on that side as well, with the donor not having to be, kept quite as long as it used to be as well. And you mentioned that the 25% increase in liver transplants in the last few years. Do you think that's solely down to the organ pump increasing the growth? Or, how significant a role do you think it's having?
Well, I think it's the primary reason. I mean, over time, again, there's been a growth of, organ transplantation. Probably 20 years ago, we were doing 4,000 or 5,000 a year. And then there's been an incremental increase, a few hundred more every year, just as our population grows and our technologies improve. But then starting in about 2019 or 2020, there was a more marked increase in the utilization of these organs. And I think it's primarily because of the
Yeah.
innovative use of these pumped organs.
And
And
this
that's
could,
and that's the primary reason for that increase in the past 4 or 5 years.
yeah. And this is just a me question, and, could be completely off the thing here. Does it have, could it be used in living donation at all, or is it,
Well, no, really, it's actually making living donation is still a very important part of the whole portfolio of what patients can utilize. Living donation is best utilized when you need speed or timing. And so for living donation, the need for it is decreasing, but it's still very, very important, especially as I'll point out in a minute, in certain select groups of patients. but this technology is not applicable to live donors. But we use live donors where we need speed or timing. And in particular, even with the increased utilization of these pumped organs, there's certain populations of people that still wait a long time. The increased number of organs is reducing waiting time, as I'm sure we'll talk about. But for particular populations, the waiting times are still long. And those are usually for small people, women say under 5'3" or pediatric patients. So if I were to die today, my liver would be so large that it would not fit into a small child. And so the number of donors who are small enough to donate to the children that need transplant is quite small, because so few children, unfortunately, become donors because they don't die. And so living donation in that population is the primary way that they get organs. So like in our pediatric program, probably 70% of the liver transplants that are done with live donors because of that. In the adult world, we see, again, women that are about 5'3" or smaller, substantially longer. And there, again, live donation works when you need speed or timing. And when you have people that are waiting longer than these smaller people, live donation is really at times their best option. The basic points would be, with the increased number of organs available, the need for live donation is decreased, but it's never going to go away in the populations that need it the most, which are children and people of small stature.
I was just intrigued. I was like, I wonder if it, passes on, but that's great to know. Would it affect, if someone's a bigger person, is it the same sort of wait times, or is that again?
So I think average size to larger people can be transplanted relatively rapidly. And again, it's the law of supply and demand. When you have more supply and a stable amount of demand, the waiting times are going to drop. And so because there's more organs, people are being transplanted faster, and the waiting times are decreasing because of that. As a general concept, it's still variable across the country.
Yeah, yeah, definitely. I think since the foundation's been started, I think the wait time or the wait list was about 120, and now we're down to 103, which is, you can see that decrease happening, which is great. We like to say it's because we do great work advocating, but I think it's more like you were
It
saying.
takes, these types of efforts and continual efforts, and just people talking. And it's mainly people should make their wishes known to their loved ones about what they want to do when they die. And it's interesting, in the past 5 years, I've had a friend of mine who was a transplant surgeon who became brain dead and was eligible for donation and went through that process. And then we had a nurse practitioner where I was employed before, who again became brain dead and went through the donation process. So it can happen to anybody, and a lot of different people.
And then can you see any key challenges in getting these organ pumps? Like you mentioned, there are a number of transplant centers using them and using them very effectively. Are there any sort of challenges you see getting them used nationwide, and really making this making every center, benefit from it?
Yeah, and I think it's individual center choice and logistics about how often they use these and exactly how they use them. Um, when you're doing a lot of transplants, I'm not a surgeon, but your surgeons are going to spend a lot of time in the air, or have a process whereby someone is spending a lot of time flying out and getting these organs and bringing them back. So it's a huge amount of work, and there's a fair amount of cost associated with the travel and also the implementation, especially the proprietary devices, which can cost upwards of $50,000 to $60,000 per case. And so that's in addition to any other costs. So the barriers are really logistics, travel, time, energy, and cost. And so it's how I think the centers that are doing the best job of this have, surmounted those barriers in different ways. But it's a colossal amount of work. The centers that are doing these are doing, combined liver and heart. A lot of these places will be doing, say, 500 solid organs, 600 solid organs, some and more. So they're doing, a solid organ kidney or liver transplant maybe every, say 500 or 600. That means they're doing a case almost every 18 hours around the clock. And so that's going, so you can imagine the amount of work, the travel, the flying, and a lot of, again, not all the organs that are sought actually end up in a transplant. So it's a colossal amount of work. and I'm just accounting really for abdominal, kidney, and liver transplant. So, heart and lung would be incrementally more than that. But again, the centers that are doing a lot of these are it's staggering to think about all the logistics that are behind pulling this off. So, and those are the barriers: time, energy, cost, travel, and then just getting sufficiently trained bodies to take care of all that.
Yeah, which is probably why you see those biggest centers really ones succeeding with it. And hopefully it'll trickle down as we get through it.
Yeah, and more people are utilizing the technology, I think.
Yeah, that's awesome. Can you discuss, so you mentioned it before, this groups of, transplant patients who this is specifically really helping that may not have been eligible or top of the list before, that
Yeah.
this equipment is helping them receive their
Yeah.
transplants. Can you kind of explain what you
Well,
mean by
and
that?
so I'm old enough to where I've been doing this since really 1992, and however many years that is. And back in those days, in those that wasn't the earliest days, but it was early days of transplant. Most centers, there were a few centers doing maybe 100 to 150. Most centers were doing 30 or 40 cases. And in those early days, the lists were really not very long. We used to walk around the hospital with a mimeographed list in our pocket, with literally 10 or 12 patients, and we'd have their home phone numbers. I mean, that's how it was done early on. There might be, where I worked, we'd have 15 or 20 people listed, and now there's places that will have 2,000. And so in those days, the people that were transplant were probably not as sick. And then in the 1990s, as transplantation became more popularized, again, the analogy is like a good restaurant in town. When people find out about it, they line up. And then as the lines got longer and longer, the organs had to be prioritized more carefully. So early on, the demand for transplant was not so much, say in the late 80s, early 90s, as it really, the growth took off in the 1990s, and more centers were doing cases and more people lined up. We had to prioritize people based on their severity of illness. And so there's been, I won't go into all the different iterations, but the MELD score is what we've settled upon now as the way that we prioritize patients for transplant. And that was developed in the early 2000s in response to just the longer and longer lines of people waiting to be transplanted, and a fair way to prioritize them and risk stratify them. And so the point of all that is in the early days, we were able to transplant people when they were less sick. We were learning more about the procedure as it got popularized. More people began to line up. We had to prioritize people on severity of illness. And then during the 2000s and the 2010s, the list went from, again, just maybe a few hundred in the United States to 5 to 8,000, or or there's probably, maybe, I don't know how many people we have listed now, but it's in 5 digits. It's probably 15,000 in the United States that are listed in that number. And so those patients had to be prioritized, and then we were only able to do the patients who are very, very sick. And there's numerous stories and experiences of people waiting in the ICUs for days and weeks and sometimes months waiting for a transplant. And that's been sort of a burden for patients, especially. Many of them didn't survive. And for providers taking care of these patients, they're not able to do the procedure because people were so sick. And what's happened in a relatively short period of time at some of these centers is dramatic. Where I work now, the number of transplants that our surgeons do has gone from 40 about 6 years ago to close to 250 this year. And so that number has gone up 4 to 5, close to sixfold if we include our pediatric patients. And then what that means for me, and what it means more importantly for patients, is that because we're able to work through all of our patients and transplant people when they're sick over a period of days and not weeks or months, that we don't, even though we're doing that many transplants, our inpatient service is maybe just 5 or 6 people, because as soon as people get transplanted, they get done within 48 hours. We had a patient who had a MELD score of 37 that we listed. Today's Monday. We listed them 3 days ago on Friday, and they were transplanted within 36 hours. And that's a routine occurrence. And so our inpatient service is so small because these people, when they get sick, they get done so fast. So that when we get those patients, they're able to be done quickly. But more importantly, there's a bigger group of people who are suffering from liver disease who may have a low MELD priority score, meaning they're not going to die over the next several months, but they're suffering and that they have weight loss, they can't work, they have mental confusion. And almost everywhere I've worked before, which have been great centers, we've not even been able to discuss transplanting those people because their MELD scores are so low that they're not really eligible for transplant because we didn't have the capacity to offer them the procedure. And so the national standards have been that you're not required medically to offer transplant for someone unless they have a MELD score of 15 or if they're having other life-threatening symptoms. Simply because there haven't we've had to prioritize patients using those standards because there's been a shortage of organs. Well, now in sort of local economy of liver that I work in now, we're really just minimally restrained by organ availability. And what's happened is we've been able to offer transplant to patients with MELD scores that are less than 15 for quality of life purposes. And I think it's medically appropriate to do that when our survival rates are top 3 in the country, as there are many other places where if you have a 96% 1-year survival rate and you're incapacitated by your liver disease, no matter what your MELD score, I think I would want to be transplanted. If I had with recurrent admissions or I had encephalopathy where I couldn't function, even if my MELD score was 8 or 10, I would personally take the risk of 4 or 6 or 8 or whatever small percent it is, to have that addressed. And so from a patient standpoint, we're able to offer that to people if they wish to transplant them at a time before that they're severely ill and are waiting and cycle through the hospitalization. I've not been able to do that before. And I tell people it really is helpful to patients to be able to offer them that procedure and not be constrained by organ availability. And it reminds me very much of what we used to do back in the 90s when we were less constrained by organs. Having done this for so many years, this is the best way to offer transplant for patients, not so much from our standpoint, but from the patient standpoint, meaning when people are severely ill and decompensated, they can be done very quickly, but also those people are getting done, but you can offer it to patients selectively who are otherwise good candidates who have low priority scores but are debilitated by their illness. So that's the change that I've seen. It's really been just dramatic and noticeable on a day-to-day basis. And it's remarkable to see people think because of what they've experienced before that when they're listed, their waiting times will be measured in years. And that doesn't necessarily have to happen. The centers that are using, I think, these pumps effectively and are able to do a large number of transplants, they've overcome the logistical problems of doing these pumps, have really been able to have such a supply of organs that been able to offer it to people who traditionally have not been eligible for transplant.
Yeah. World of difference then when Chris, waited 6 years for his.
Yeah.
And I'd imagine too that, and this could just be me imagining this, but that these patients who get their transplants sooner, who maybe wouldn't have before, have a quicker recovery time, given that they didn't get,
Well, yeah.
quite so.
So again, I think that's a plus for it. And so the recovery times are faster and it's a more effective from a policy standpoint. This is a more effective way to do transplants. And frankly, around the world, except for the country of Germany and the United States, most people are transplanted at MELDs of 15 to 17 for
Mm,
this very purpose, because from a policy standpoint, it's the most effective way to utilize the procedure where you save money by transplanting people before they cycle through all the complications they have. And then the recovery times are so much more effective.
yeah.
And so everyone in the US would do this if they were able, but we haven't been able to do this because of the shortage of organs that we've had. And we still have a shortage of organs, but in places that are utilizing these pumps, it's making that much less of an issue and offering the procedure faster to sicker patients and making it available to people that are less sick who traditionally weren't considered for the procedure. And that will include older people. As people age, as I'm finding out that, you get sicker and you develop problems. And when people get over the age of 70, most of the time, when you put them under a CT scan or get them on a treadmill to do a stress test, you're going to find that their bodies are strong enough to take the stress of having a transplant or all the medications and side effects afterward. But if you can transplant people before they're so sick and they sit in the hospital and become weaker and weaker, we've been able to offer the procedure to select people over the age of 70 into the mid 70s. And I'm sure there's been people older than that have been done, but it's opened up those bars because of the availability, because they don't have to wait so long. If in many places and up until a few years ago, if you were 70 years old, and that your MELD score would be 28 at the time of transplant, which is average in the United States, it's very hard to keep people alive um, while they deteriorate and get an organ, because they have to become so sick to access the organ. And so um, many of those patients again have not been eligible before. And then we've had patients who have needed a kidney and a liver transplant where we've been able to offer them that combined procedure before they even go on dialysis, because their priority score would be high enough to get a liver and a kidney, where again, historically, they would have to become sicker, or maybe not, unfortunately, die on the list waiting for so long to get a combined organ. So it's offering, the procedure to these different subgroups of patients who might not have been eligible otherwise.
That's huge. Yeah, definitely getting people off that list before you start trying to play the balancing act of you need to be this sick, but you can't get any sicker than, that.
And we talked before we were on the air about, I don't do kidney transplant, but the same rules are applying at our kidney transplant program, where it's just astonishingly, our wait times for kidneys are 8 months. And historically, again, most other places I've worked, it's been 4 to 5 years. And so the effective use of these organ pumps has allowed the same principles to be applied I don't know about thoracic transplant, but definitely kidney transplant. And doing patients that quickly, preventing them from languishing on dialysis, is just amazing. And when I heard, I had to almost check the numbers to make sure there wasn't an error. But those same processes are applying in kidney transplant as well.
Yeah, helps them get back to, living life rather than sort of surviving, as they say. Yeah. And then, obviously there's been a lot of talk recently about pig livers and, bioengineered livers and things like that. How do you see this, the organ pumps affecting that?
Well, I don't know. I don't know, because that's there's a famous saying that xenotransplant, which is pig transplant or animal transplant, xenotransplant is the future of transplant and always will be, meaning that there's been many disappointments along the road. That's not a very optimistic view. It's been true up to this point, but I think a lot of transplant professionals are envisioning the day when there's been publications now of xenotransplanted kidneys that have been performed, and I think we're getting closer to the time when that's possible. And so I don't know what will happen with that clinically, but I think we're getting closer and closer to where that might be possible. And that would be very, very exciting to offer that to people. The cost of it will be interesting. But again, there's been some real steps forward that have been popularized in the press that are true about the use of xenotransplant on a limited basis. So I don't know how that would apply. We look at each other here, and we had a guest speaker coming and speaking about that. And our waiting times today are an average of 9 days for liver transplant. And we look at that and say, well, where would we apply, say, a pig liver into that process when an average patient is waiting just over a week? And right now, for our general population, we wouldn't have a need for xenotransplant because we're unrestrained in our availability of human organs. But I think we're close. I don't know the answer to your question, other than we're getting closer. There are real steps that have been taken where this has worked, and I suspect, like a lot of things, it may not replace if it becomes available. I think it'd be difficult to replace human transplant, but there could be sectors where it could be used again for liver, small patients who don't, they could have an organ maybe custom made in a sort. There's patients who may be difficult to match organs for in different types of, for kidneys, where these pig organs may be more effective. And so there could be specific areas where it will be very, very beneficial, or maybe it'll replace everything. I don't know. But currently I look at it and think, wow, we have a lot of human availability Right now, we're not restrained right now for the most largely by organ availability. But the amount of energy and time that goes into harvest procuring those organs, dealing with, deceased patients, the emotional part of it, the travel, all the logistics that are just, staggering. If you had a more, organized supply route, so to speak, or supply chain organs that were available through, say, pig production, it would make the process much more efficient. And we're getting closer, but I don't know if that will ever replace it altogether. But there obviously there've been a lot of breakthroughs recently. So I think if Xeno did take over, the advantages of it would be just reducing all the logistics that are complicated for human donation and more reliable supply chain. The downsides, of course, are that these are still pig organs. There's a way to humanize them, to make them, and many different technologies that would allow that. And then the cost of it would probably be extraordinary. But there's pluses and minuses. And I doubt if the foreseeable future, that human donation would go away. But I think we're getting closer to where Xeno could augment what we're doing.
I think it's exciting times in the world of medicine, I think. There's all these different, unique new things coming through that can really make a difference to our patients and those that, we talk to day, and went through this whole process. I
Well,
think
and
it's
it's become a lot, again, I look back on my career and I'm still active in my career, but having seen, when we did a transplant when I was in training, it was almost like when we did the first moonshots. I remember when we would Apollo 7 or 10 or whatever would go off, people would gather around the TV and watch. And it was wow, it's a national event. And when we did transplant in the early days, we were doing, say, 30 or 40 or 50 a year. And each case was an event where, oh, we're going to do a case today. Let's make sure we've got to check all these things. And it was like a moonshot. And today, we're doing, like, we do one about every 36 hours here now. And so it's not routine, but it's become more, um, industrial or popularized. The system works awesome. It's geared up. All the patients are cared for appropriately, but it's so different than it used to be because the volumes are so much higher. The systems are so much more efficient. I mean, when I did this before, we had maybe two or three surgeons and two or three hepatologists and two or three nurses. And now I think we have probably 12 to 15 physicians, and I think we have 29 nurse practitioners and 30 nurses, so just a staff of maybe 80 people to do this. And it's, it's so much bigger than it used to be. And the people are so smart and well trained. It's made it so much more efficient. It's so different than where it was. We can evaluate people so fast, and we have efficient systems to do that. And it's not like a moonshot every time, but because the systems are so well oiled and efficient and well done, it's so different than the way it was 30 years ago.
my dad actually, not the same. He had a quadruple bypass last year, and his doctor, sort of looked at him. And I think it's kind of the similar thing for transplant too, and said, this may be, a life experience for you and a huge one. But for me, this is my day. This is routine. Like, I got you. We're getting through this. And he was like, it just, a wave came over me. He went, my dad's a farmer. And he's like, so he's just basically feeding his animals for the day. That's the equivalent of what he's doing in his day by giving me my surgery.
Well, and if you take it, I've never been a transplant patient, but if I always just reflect, that we've had people that get sick very, very quickly, and you go in the room and say, well, you're going to need to have a transplant, and it's going to need to do this, and this, and you'll be in the operating room in 6 weeks. And if someone told me that, I would lose my mind. And, because it's like, well, there's got to be a different answer. There's got to be some other way. And then, medical professionals get upset when people don't, toe the line. But from a patient standpoint, it would be terrifying to just think about you're going to do what, and like, and then how much is this going to cost me and my work and my family and me, and like, how's this all going to work? And it's like, well, did we do one every 36 hours, or we're doing a solid organ, every 18 hours. And so it's the difference between individual people, and I think the system is different. And for us, it's something we always have to remember, because As my aunt used to say, a minor surgery is surgery done on other people, you know, but any surgery, especially when you're talking about a transplant, is a huge undertaking. And just to stare down the barrel of that, you may have some experience with that. It's just, um, I would think would be very, very frightening. But I guess it is from the patient standpoint, some consolation that, well, I guess they do this all the time. It's not that big of a deal. But if it were me, it would be a huge deal. And I would have a huge amount of anxiety about all the risk. And so I think that's the problem is we're doing a lot of transplants and people recover quickly and so on, but not everybody does well. I mean, we have, a small percentage of people that will stay in the hospital for months, and those cases are very, very hard to predict ahead of time in most cases. And so, and it's that wild card of it that makes it most difficult if you have someone, that has just a bad outcome or difficult or complex outcome, just dealing with all the logistics of that, especially as patients are traveling more and more. We live out, you live and I live in an area that's dense, has dense population centers, but outside of Denver and Salt Lake, there's not a lot. And so people travel in the Mountain West a long way. And 2/3 of our patients are coming from outside of Salt Lake. And some are coming, we'll have people come from the far reaches of Northeast Montana, which will be maybe 12 to 15 hours of driving, the distance between like Kansas City and Chicago. And just getting, if you're out there or you've had a transplant and you get sick, your resources for care are very, very limited. And so that would be even more frightening. And that's true for a lot of our patients because of how far away they travel. We do outreach, and more programs are doing that where we go out to, we go to Boise and Billings. I spend 4 days a month in Boise, where and we're going to start up in Billings, and we go to St. George, and a lot of programs here in the Mountain West, in fact, over the country, go out to these places, because we have such good air travel, and there's a need in these places for complex care, and that's another part of the business that has really grown in the past 20 years is outreach clinics for liver disease. We probably do about 15% of our business in outreach, up into which is a lot, and the logistics of it are complex.
Yeah. Especially when you add in, like, up here, I know the mountains add in a whole new thing for everyone. Uh,
Travel, getting over the passes.
the pass is I mean, we were chatting with a lady the other day whose husband was doing dialysis, and our closest center is about 2.5 hours away from them. And of course, snowstorm hit and they couldn't get out of the valley, and she said it was one of the scariest things. Uh, know that you need to get him to care, but you can't do anything because there's nothing nearby, so outreach is a huge, important part, especially for Colorado, but a lot of these other, more remote areas as well.
There's a great story just a diversion, but a great story on the Weather Channel about a case that was done at the University of Colorado, and the surgeon was Jeff Campson, where there was an organ at Vail where the organ teams had flown into Vail to procure the organs from a deceased donor. While they were there, there was a snow dump, and it closed I-70, and the organ had matched for a patient in Denver, but the airports were closed and I-70 was closed as it does during a big snow dump. There was a hospital employee, I think worked in the operating room, who had hopped up four-wheel drive, and they talked the Colorado Highway Patrol into allowing them to get onto I-70 and drive from Denver up into Vail to get the organ and drive it back. And they basically told them, you're on your own, like, we're not going to come get you. And they were able to go up and take the organ and drive it back down and do the transplant. And it was, an amazing story. But it underscores just the difficulty of travel in the Mountain West, because as we all know, those things can happen like that. And then the roads are closed, the airport's closed, and there's not much anybody can really do about it.
Yeah, that's an incredible story. I have to look at that one. That's
There
amazing.
was another one where a patient got from Wyoming, where the Wyoming Department of Transportation plowed with the assistance of the Highway Patrol, plowed, uh,
Through.
I-15 down into Denver from up in Casper to get a patient down. So there's people are very resourceful when they have to be, but it's remarkable.
Incredible. There's so many heartwarming stories in this world. Well, thank you so much for joining me. I always leave our listeners with sort of a piece of information or advice or inspiration that maybe you want to leave them with. Sort of, any last tidbits that you want to pass
Well,
on.
I think the main thing, if I were a patient, I would want to be informed about to be aware that the number, for at least from a liver, that's all I can really speak to, the number of organ transplants has gone up dramatically because of these organ pumps. There are multiple centers around the country that are pretty dispersed from Tampa to Salt Lake to Indiana to Cleveland to Houston to Phoenix, where these organ that are utilizing these organs particularly well, and the waiting times are quite short. And if I were a patient, I'd want to be informed about availing myself to, utilizing those opportunities. It's not easy, and you want to make sure whatever you do it for the long run, because if you travel to be transplanted, you want to make sure that you have good care before, during, and after. But this is growing, and I'd be informed and watch. It's very exciting in the business to know that these opportunities are out there. But I think there's a lot of hope for, again, more organ availability and widening use of these increasing number of organs for a whole variety of patients.
It's incredible. Yeah. Thank you so much for joining me. This has been amazing. And as always, thank you to our listeners for tuning in and keeping this podcast going. And as always, we hope you continue to live life, give life.
Thanks very much.